Good. All right, welcome everyone to the Lunch Learn Link seminar today. This is a seminar sponsored by the Sidney Kimmel Comprehensive Cancer Prevention and Control Program and funded in part by the Maryland Cigarette Restitution Fund program at Johns Hopkins. And we have speakers 1 or 2 times a month during the academic year, so I welcome you. If by chance you heard about it through a general mailing and would like to get a notification about every one of these seminars, just leave your email with me or leave it at the table in the gallery. We do have pizza afterwards, so make sure you get a ticket. Nicole will probably be on that side of the auditorium handing out tickets, and if you don't get one now, you can get one on your way out. So that entitles you to some pizza and salad. We welcome also the audience that's online. So today we have a broadcast of the lecture, and we are recording it. So if you or your colleagues would like to view the presentation later, you can find it on our website. And from time to time, we let people know when the lectures are up and the address where you can find them. So today it's my pleasure to introduce Nicholas Papadopoulos from the Sidney Kimmel Comprehensive Cancer. He's professor of oncology and pathology in that department, and a member of the Ludwig Center for Cancer Genetics and Therapeutics. So it's an elite group that actually does a lot of, road work for the rest of us, making the path clear as to how to approach some of these problems. So as an epidemiologist, I'm particularly interested in how what Nick is studying applies to public health and actually screening for cancer. And he and I were just talking about this, and its day will come, but right now the science is probably in diagnosis and treatment more than it is in early detection and then making an impact there. So let's welcome Nick Papadopoulos.
Thank you. It's my pleasure to share with you our work at the 5th floor of the Cancer Center, and all the colleagues that you will see there. I will reference them. I don't know if I need to have disclosures, but I do have. Do I need to use this to? Sorry. Just in case, I don't know if that was a prerequisite. I have some co-founder shares in 2 small non-public biotech companies, and I'm a consultant every now and then for another one. So I think we have been sacrilegious not to say anything about prevention here in this building, so I just had one slide. That perhaps, all of us would try to reduce cancer deaths in different ways. And of course, prevention for cancer perhaps is the one that can address most of the cancers. It's as Benjamin Franklin said, an ounce of prevention is worth a pound of cure. And there are a lot of usually good things that we have to avoid, like food and exposure, like sunbathing, smoking, that actually can prevent cancer from developing. But that still, we do get cancer. A lot of people do get cancer, and we have to treat them. And treating advanced cancers is very challenging. This is a young individual that has melanomas, and he has a mutation in a gene called BRAF. So there were targeted therapies, right, towards the mutation of this gene. So they do work. That's just a few weeks later. But then that's the problem treating advanced cancers. At some point, most of them, they come back, and they come back with a vengeance. And unfortunately, at that stage, there isn't much that we can do. That doesn't mean we're going to stop trying to develop more drugs, so we have to, but apparently treating cancers earlier, it might be easier. So how do we detect them? And that will be the main theme of my talk, trying to detect cancers earlier, secondary prevention, if you wish. We call it early detection. And I'll try to take you through a journey that we went through to try to develop, eventually maybe come to a screening test that actually works well. The last, 10 years or so, a lot of genomic information from all these cancer genome centers, and here at Hopkins, we have, the sequencing or the genetic landscape of cancer, so we know the majority of genes that are mutated. So how can we put this information to work? For one of the first applications for years, actually, using DNA for analysis and in management of cancer is to detect germline mutations in families that are predisposed to cancer. And of course, that germline mutations, I'm not going to be talking about that's one of the first applications using the genomic information. All the way to the other end, from risk assessment in people that are in higher risk to actually having a cancer, analysis of the tissue itself. This example is of colorectal cancer, the different stages, but analysis of this tissue and understanding the mutations that are present, it can still help us with prognosis, response to prediction, even molecular classification of the cancers. But then there is the in-between, as I say, between not having a cancer and having cancer, and how do we deal with that? There are situations where people, for example, had surgery or therapy with intention of cure. And then always the question is, are there any cancer cells left inside this individual? Or where biopsy is not available, can we get information that actually can help the patient? And of course, we have healthy individuals that start getting older, like me, and then you start wondering, do I have a chance? What is my risk of getting cancer? Is anything start happening and I don't have any symptoms? Circulating tumor DNA, as I will try to show you, can actually help us address some of those situations. So what is circulating tumor DNA? It's DNA that is present in the cancer cells that finds its way into this bloodstream. The vast majority of the DNA in the circulation actually is not for the cancer cells. It's the minority of the DNA that comes from cancer cells, and that's what we're interested in. It's in the forms of free DNA. It's small in size, 200 base pairs or so. The half-life is about 30 minutes or so. The amount is very small, very few molecules, and also it varies from situation to situation. And you can also see there are circulating tumor cells themselves, or pieces of cells that they contain it. I will be talking about the naked DNA in the bloodstream, and that is what the research that I'll show you is targeting. So having been able to analyze that DNA, and going back to those questions, we can, in the case after surgery or therapy, as we call it, that's a form of early detection, like trying to find, is there any minimal residual disease, or there is a resistance that is arising in the patient after the treatment, and can we detect this earlier than imaging, for example, or other methods, and that will be useful too. In the case of no biopsy, and I'm not going to talk about this situation in this talk, again, looking for mutations in the circulation, it can actually help the physicians manage the individual by, let's say, finding mutations or other genetic changes that they can point them towards some therapy. And of course, perhaps more important is, can we use this to actually have tests for early detection and screening of the population before they have symptoms and detect cancers very early. There are challenges to develop those tests. There are technical challenges. Can we develop those tests to have sufficient specificity and sensitivity? There are biological challenges. Every tumor, for example, sheds DNA in the plasma, and will we be able to, what can we detect in plasma or other bodily fluids. And of course, assuming we're going to go through those challenges successfully, interpretation of the results will be the next step. Starting with the technical challenges, we need markers to develop the test. I'm going to be talking mostly about markers that we use, and those are tumor DNA. With that, what I mean is we're targeting somatic mutations, there is point mutations, indels, translocations, rearrangements, even methylation markers that are present in the cancer cells, and then they find their way into the fluids. Why we like to use those? Well, by definition, I'm not talking about germline mutations. Those are somatic mutations. So by definition, they are present only in the cancer cells and not in the normal cells. So that provides exquisite, or at least in theory, exquisite specificity. We know from all the genomic studies that there are present early stages and and before metastasis. So that provides a window of opportunity when we detect them to still have early stage cancers. We like the fact that they are directly related to the pathogenesis. Actually, they are causative to cancer, like KRAS mutations, for example, or other cancer driver gene mutations, as we call them. And by now, we know that they are detectable in a lot of different bodily fluids, and that usually that allows us non-invasive tests that equates to no harm or less harm than other procedures, and hopefully higher compliance than what we get now, for example, with colonoscopy, which is a great test, but a lot of people refuse to do it. It is the proverbial needle in the haystack. In the plasma, there are like very few molecules, 1 to 5, and I'm not exaggerating, tumor DNA fragments in a sea of thousands of DNA fragments that actually have the wild-type sequence. So how do we detect this? One way to find the needle is you can take the hay, one by one. And back in 1999, my mentors and directors where I am, Dr. Vogelstein and Ken Kinsler, actually published a paper called Digital PCR. And the idea was basically going for an analog setting of analyzing mutants, which you can see if you analyze all these molecules together, the signal of the mutant is drawn from the signal of the wild type, and it's very hard to detect. But if you analyze each molecule independent of each other, you get two things. One, the signal of each molecule, it doesn't matter if it's a mutant or wild type, they will be equivalent. And then also it allows you to quantify the number of the mutant molecules that there are present in the fluid that you're examining, allowing you to perhaps get an idea about the burden of the cancer cells that is present in the individuals. So that was actually a pioneering paper. There are a lot of reiterations and adaptations of digital PCR. There are machines actually now that they do it. I'm not going to go through these technical details. But in our group, as a next step, what we wanted to do was actually to adapt this technology to next generation sequencing. And the reason for that is because it has some characteristics that we like. It is digital, which means that each molecule can be analyzed independent of each other. It is high throughput and automatable, which we hope that we don't only hope, we've seen how this can translate to actually cost savings. But it had a big disadvantage. The error rate is very high for some of the clinicals, or most of the clinical applications that I'm going to discuss today. The error rate is about 1%. I already told you that we like to detect 1 to 5 molecules in 10,000 molecules. So that was not acceptable. It wouldn't work. Isaac Kinden, MD PhD student here in our group, tackled that issue, developed a technology which we call Safe-Sequencing system. It is a digital technology, and it is adapted to next-generation sequencing. I'll show you only a couple technical slides to try to explain it. There are some essential elements of Safe-Sequencing system. You start with, if those were the molecules, the starting molecules that they were present in the fluid that you want to analyze, in the sample you want to analyze, the very first step is to associate those with what we call UID identifiers or molecular barcodes. And then these molecules go through a process of PCR amplification. There are a number of steps that I don't have here. Eventually, they get sequenced. And in the end, we bind together, if you wish, all the molecules that they have the same UID. And the idea is that all these molecules are daughter molecules of the initial molecule that it was present. So the way it works is this is an example of the DNA primer. It's a Safe-Seqs system. It has an area starting from 5' to 3' that is universal to every primer. It has 14 ends. That's a random nucleotide barcode. So that gives you about, I think, 294 million different combinations. And then it has a region for your favorite gene, the gene that you want to target. So if you want, for example, to target KRAS, each molecule of KRAS within the same sample, it will get one molecule is going to get UID, let's say 1, the other molecule UID 2. If you want to multiplex this with other genes, P53, let's say, that will get another UID, another molecule of P53, another UID. I think you get the idea, and that's the most important step, the very first step, making each molecule having its own UID. And then we can amplify the signal utilizing the universal ends of these primers. And that's how we call mutations and why these allow us to reduce the error. We take, let's say, UID1, all the molecules that they have UID1. If they have a mutation, that's a mutation that it started, it was in the starting material. If none of it had, well, that's a wild type. But if in another family, if you wish, of molecules that they came from the same starting molecule, if some of them only have a mutation, that means that that was an artificial mutation, that it was created either in the PCR step, the sequencing step, or even in silico in the analysis. And that gets eliminated. That actually helped us go down in some situations to 0.01%. You can always improve technology. We thought we had good enough technology to start actually developing tests. And then we moved to the biological challenges. All right, we want to develop a plasma test. What tumor types can we detect there? So you can see this as a control experiment. This is, of course, in the control experiment, we used metastatic cancers, late cancers. And the idea was if we cannot detect metastatic or advanced cancers, there is no way we're going to be able to detect early cancers. So we had both tumor and plasma from these individuals. We sequenced the tumor, so we knew what mutations were present in these cancers. And then we looked in the plasma using these technologies that we developed. How many times can we detect the same mutation that was present in the tumor? And here's a summary of the results. Those are the different tumor types. It was kind of like any tumor type that we can get our hands on. And this is the percent or our sensitivity, if you wish, to detecting them. For most of them, actually, plasma was pretty good. We detected, I don't know, some of them 100% of them, some of them above 75% of them. But clearly, it doesn't work for every tumor type. I know that some of these numbers are small, but those are barely 50% of the samples were detected, or less actually than 50%. So plasma is not going to fit for every cancer, or at least that's our interpretation. And of course, for gliomas and CNS tumors, perhaps predictably, the sensitivity, maybe it's there, whatever, 5, 10%, it really was 0. Also, what was interesting was that actually this is the same experiment, but now showing the average amount of DNA. I told you that these technologies allow us to actually count the wild-type molecules. And there is some good correlation between the amount of DNA that is circulating tumor DNA that is present in 5 mL of plasma and our sensitivity in detecting them. And that's not necessarily a surprise. I mean, you have more molecules, it's easier for these technologies to detect them. Also, this is only with colorectal cancer, and this is using some older technologies. But the point here is that actually we can detect a again, going from stage 1 to 4, our sensitivity is better, at least in colorectal cancer, in detecting later tumors. And that, again, kind of correlates with the amount of DNA that is present. So working on increasing the sensitivity of these technologies or using perhaps more material, which is more difficult, it can help us increase sensitivity. So liquid biopsy, as a summary of what I saw you, most tumor types are being detected. There are multiple tumors that can be detected at the same time. If individuals have two, let's say, different tumors, that we can detect both of them. And of course, it's easier to detect later stage cancers. So I'll move actually to the applications, which is perhaps the most interesting part. And I'll start with monitoring. And that actually was, this idea was set up here at Hopkins back in 2008 with these people, Frank and Kirsten, actually were postdoctoral fellows in our group. And I think you guys know Michael Chody and Luis Diaz are oncologists. And along with Bert Vogelstein and Ken Kinsler, they decided to actually follow the patients that they had colorectal cancer, that they were taking different treatments, and follow them by looking what happens to the circulating tumor DNA. And so that was one of the first demonstrations that actually looking for mutations in plasma, it's actually a dynamic process. You can see that, this is a time, and this is the amount of circulating tumor DNA by looking at mutations. So it goes down after surgery, predictably, I guess. After chemotherapy, it even goes down. When recurrence happens, it comes up, and there is a spike. And this particular individual had a second surgery, and then chemotherapy, and so on. So it followed really well, and that was one of the first demonstrations that actually we can use that marker to follow patients. And in the same study, looking at measurements after 6 to 8 weeks following curative resection in colorectal cancer, they looked at CA and circulating tumor DNA. I know that there are very few samples, but that really set up the stage for trying to test ctDNA as a predictor for recurrence. So to do that, we collaborated with Peter Gibbs and Jenny T in Australia. So all of the samples were from Australia. The study was published this July, and it was focused on colorectal cancer. We know that 80% of colorectal cancers can be cured by surgery. But then there is always the question, what do you do with, what happens to the other 20 people? How do I identify the other 20%? And a lot of them get adjuvant chemotherapy, and they're offered based on some high risk factors. But there aren't really good indicators to who needs that chemotherapy or not. So we tried to see if actually circulating tumor DNA, it was a good predictor to identify these individuals, the ones that they recur. So the study was a prospective study. It had 230 patients with resected stage 2 colorectal cancer. We had plasma 4 to 10 weeks after the surgery. And for 167 of these, actually, we had serial blood draws every 3 months. Overall, we analyzed more than 1,000 plasma samples. In the same time, these individuals also, they were surveyed every 3 months with CA and every 6 months with CT for 2 years. Median follow-up was 27 months. And based on clinical factors, risk factors, it was up to the discretion of the clinician to assign some of these individuals to chemotherapy, and 52 of them were actually treated. We had the tissue it was surgery. So we looked at the 15 genes that are commonly mutated in colorectal cancer. So we identified mutations, and then we actually looked in the plasma for these particular mutations. So it was personalized, if you wish, test that to develop for different individuals. And having a PCR-based actually test, it makes this personalized testing much easier than, for example, sequencing with a capsule, the 15 genes in every single individual. the data, the summary of the data is as follows. This is based only on clinical risk factors, and you can see that indeed, based on the factors, there is stratification of, it can predict a recurrence, or the ones that they have low risk, they have higher chance of recurrence. The ones that they are high risk, they have higher chance of recurrence. The ones with low risk, lower chance of recurrence, with an HR of 3.3. But looking at the ctDNA as a marker, it was a completely different picture. And this is from the individuals that they had surgery but no chemotherapy. So from ctDNA, actually after 3 months, everybody who was positive for ctDNA 6 to 10 weeks after the surgery, it recurred. Of course, there are some, you can see from here, there are some ctDNA that there were some individuals that they recurred, although they were negative for ctDNA, but the ones that they were positive, all of them actually recurred by 3 months. The ones that they actually were, they took chemotherapy, they were assigned the chemotherapy arm. Again, we looked after the end of chemotherapy if ctDNA can be a good marker for recurrence there too. And it was. Again, this is a smaller sample, of course, because fewer people got chemotherapy. And the way that we had serial samples, as I told you, for especially the people that had chemotherapy. You can see the blue is the ctDNA. You can see the levels of the percent mutant alleles, how many mutant alleles are present. They go down with chemotherapy, but in some cases they recur, and they recur a lot actually faster than what a recurrence was detected with imaging. And of course, in some cases, fortunately for these individuals, ctDNA went low and it stayed low, and after 30, in this case 35 or so months, this patient was cancer-free, or and still, my understanding is they have not seen recurrence after whatever 40 or so months now. So ctDNA was a good marker for recurrence, but besides using it in that setting, we also think that it could be a good marker to now stratify individuals that they have stage 2 cancer and surgery, and use that as a design for trials to really determine who really needs chemotherapy, and if chemotherapy indeed is useful in that setting, because as I told you, its use is controversial. So instead of getting everybody and trying to assign chemotherapy based on some risk criteria, what we hope in the future in setting up a trial for that is to stratify, identify the ones that they have ctDNA in their plasma, which means that they're going to recur, and then use those to test different chemotherapy regimens with the hope to really understand what works for these individuals or not. So as a summary of this study, ctDNA detects minimal residual disease, and it's a good predictor for recurrence, both after surgery and after the chemotherapy. In serial ctDNA measurements can provide a real-time quantification of the disease burden. I didn't show you the detailed data, but also the time between ctDNA detection and recurrence determined by imaging was on average 167 days earlier, and that could be important for the individuals to detect these cancers earlier than it can be detected with other technologies. And of course, select, as I saw you in the last slide, individuals for adjuvant chemotherapy trials. So detection of resistance is another application. Again, this is in the realm of detecting it earlier than, detecting cancer that it comes back earlier than other methods. In this set of samples, there were 25 cases that they had metastatic colorectal cancer that initially responded to EGFR blockade. In order for a patient to take EGFR blockade, it needs to be negative, at least for a set of mutations, including KRAS, BRAF, and EGFR. So for these individuals, which are here, oops, sorry, the patients, we actually had both plasma before treatment and after treatment. And those are the genes or the mutations that we actually tested for their presence in the plasma of these individuals. And of course, before treatment, they were negative. In order to get this treatment, they had to be negative. But after treatment,